Hello, welcome to Migrant Belgium. My name is Benjamin, and today I'm going to be talking about rheumatoid arthritis. And this is one of the most important autoimmune diseases. It is a systemic autoimmune disease that is characterized by persistent symmetrical polyarthritis as well as extra-articular manifestation. So in this video, I'm going to cover the pathogenesis of the disease. I'm going to cover some etiologies and risk factors, its extra-articular as well as the articular manifestations. I'll look at how we diagnose it with the criteria from the European League Against Rheumatology. And then I'll cover also two syndromes that are important when it comes to rheumatoid arthritis on examinations. That is the Kaplan syndrome and the Felty syndrome. So when we look at the risk factors and the etiology, it is believed that genetic factors are going to play a big role when it comes to the development of rheumatoid arthritis. Genes like the HLA-DR4, HLA-DR1 have been associated. And when you look at environmental factors, strong links have been made. For example, smoking has been found to worsen the disease, and also the disease is commonly seen among smokers. Infections like Epstein-Barr virus, as well as changes in the gut microbiome, have been linked to have an association to this disease. Then when it comes to the hormonal, it has been found to be more common in females, and sometimes pregnancy has found to improve the disease, as well as sometimes the first episode happens of the rheumatoid arthritis during the postpartum period or during the puerperium. So when it comes to pathogenesis, what happens is that we need the person to be genetically susceptible as well as have the environmental factors in place. So when these two things come together, they probably the smoking, the infection are going to cause a prolonged immune reaction or inflammation. And this is going to cause a conversion of arginine, which is an amino acid found in the proteins in the body, to citrulline, and we produce what we call the citrulated proteins. So these citrulated proteins are new to the body. The body has not seen them before. What it's going to do is that the dendritic cells are going to present them as antigens, the CD4 T cells. And the CD4 T cells will go ahead and activate the B cells, produce the autoantibodies. And these are going to be against the rheumatoid factor, which is going to be against a point on the IgG antibodies called the Fc region. And then we shall also have the antibodies against citrulated proteins. So the anti-citrulated protein antibodies, sometimes they actually look at a specific type of citrulated proteins, which are the cyclic. So we have the anti-CCP, which is the anti-cyclic citrulated protein antibodies. Then when this happens and have antibodies, inflammation is going to occur. And during inflammation, cytokines are going to be produced. And these ones are going to be deposited on the synovial membrane. And when they are deposited on the synovial membrane, we shall have a synovial hyperplasia. And when we have a hyperplastic synovial membrane, it is going to be called the pannus. So what happens is that this pannus is going to be highly invasive. It's going to erode the surroundings of this synovial fluid, and we shall have things like joint destruction happening. The T cells are going to activate the rank pathway, where we shall have osteoclastic activity, and that is going to cause the bone erosions. Then we shall have also the systemic effects of the cytokines, like the inflammation, and this is going to cause a fatigue. It can cause anemia, like anemia of chronic disease coming from the prolonged inflammation, leading to increased hepcidin. And when hepcidin is high, iron availability is low, as well as the bone marrow is suppressed. And that is anemia of chronic disease. So we're going to look now at the clinical presentation of the disease, and it's going to be mainly affecting the small joints most of the time. And when it affects the small joints, the hands, the feet, and the wrist are going to be the most associated. And extra-articular features are also going to be very, very available. So the onset patterns are very important, because we can have an acute setting and we can have a polymyalgia rheumatica-like presentation as well as a palindromic. So the acute presentation is going to begin with early morning stiffness. We can have a polyarthritis as well as a heating edema. Then the polymyalgia rheumatica-like presentation is going to be characterized by proximal stiffness. In the palindromic one, is going to have brief relapsing and remitting episodes of the rheumatoid arthritis. Then when we go on examination, we can have the joints. And at the joints, we can see swelling or tenderness. And sometimes if there is erythema, we can suspect maybe there's a secondary inflammation happening. We can have hand deformities like the ulnar deviation, the swan neck deviation, the bâtonnier's deformity, as well as the zip thumb. Then when we go to the wrist, we can have dorsal-ulnar subluxation. When we go to the fingers, we can have trigger finger from tendon nodules, because rheumatoid arthritis tends to have this development of nodules within different structures. So if it happens in the tendon is going to be pulled on and it's going to shorten, and that is what causes the trigger finger deformity. Then it can also affect the feet, and shall have subluxation of the metatarsophalangeal joint, and we can have the cock-up toes, we can have pain, we can have callosities developing, we can have hind foot valgus, as well as a flat foot. Then in the knees, we can have development of a Becker's cyst, and this is important because if a Becker's cyst ruptures, it may cause a lot of pain, and it may also mimic a DVT. So it is a good differential to know in people having rheumatoid arthritis. And when we come to the extra-articular manifestations, we shall have the general ones, which are basically fatigue, fever, weight loss, and this is coming from the inflammation going on. We can have development of skin nodules, and this is going to mostly occur in seropositive people or people who have the positive rheumatoid factor or anti-CCP antibodies. We're going to develop these nodules, and sometimes these nodules may ulcerate, and we can also have infection. We can have in the lungs, we can have interstitial fibrosis. We can have nodules developing, and that is going to be covered more even in Kaplan syndrome. We can have a pleural effusion. We can have bronchiolitis obliterans. Then in the heart, it is very well possible to have a pericarditis, myocarditis, and increased rate of coronary artery disease because of this inflammation going on. Then when it comes to the blood, we can have anemia of chronic disease, Felt syndrome, which we are going to cover, and this is a very high yield when it comes to some of the syndromes like Tronexams in rheumatoid arthritis, then amyloidosis. Then the eyes, we have keratoconjunctivitis, and this is also called a secondary Sjögren syndrome, whereby we have the destruction of the glands supposed to produce the tears in the eyes, and we end up with dry eye. Keratoconjunctivitis, scleritis can develop scleritis, and we can have neuropathies coming in, where we can have a small vasculitis called disrupting the vasovasorum, which are the small blood vessels that feed the nerves, causing nerve death or neuropathies. Then we can have entrapment because of these different features, maybe at the joints. We can have cervical subluxation, and when we have cervical subluxation at the anterotaxial joint, we may actually have compression of the spinal cord, and this is going to be an emergency. Someone could lose their life or even have permanent spinal cord disability, and I covered spinal cord disabilities in a video. I'll leave it at the end of this video where you can go and look at those different syndromes. Then we can have renal, where we have amyloidosis, drug-induced nephropathy, and we turn to the bones and muscle, we can have osteoporosis. So this is going to be majorly the clinical manifestation of a disease. So if at this point you feel like you have covered already a good work, I would encourage you to like the video, subscribe, leave a comment, and ask me a question, and I'll try to answer it. So when we go to the diagnosis, we're going to use the criteria, the 2010 criteria from the European League Against Rheumatism, and it is going to have a score, a total score of 10. But when we have a score greater than 6, we consider that person to be having rheumatoid arthritis. So it considers 4 parameters, and that is joint involvement, serology, where we do the rheumatoid factor and the anti-CCP. Then acute phase reactants, that's the ESR, also like erythrocyte sedimentation rate, and the CRP. Then the duration should be about 6 weeks. So when we look at the joints, if we have one large joint involved, we normally give it a 0, because rheumatoid arthritis does not affect large joints normally, and it's a polyarthritis. If we have 2 to 10 large joints, we can consider giving 1. If we have 1 to 3 small joints, regardless of whether there is a large joint or not, we give a 2. If it is 4 to 10 small joints, whether there are large joints involved or not, we give a 3. And then when we have more than 10 joints, more than 10 joints, and more than 1 small joint affected, we give it a 5. Then we look at serology. If we have a negative rheumatoid and anti-CCP, we give a 0. When we have a low positive for these ones, rheumatoid and anti-CCP, we give a 2, and the high positive will give us a 3. We go to acute phase reactants. If we have a normal yes or a normal therapy, we give 0. If we have an abnormal yes or an therapy, we give a 1. And then the duration, if it's less than 6 weeks, we give a 0. If it's greater than 6 weeks, we give a 1. So now I'm going to cover some of the 2 syndromes that are commonly seen in this condition. And that is going to be the Kaplan syndrome and the Felty syndrome. So when it comes to Kaplan syndrome is going to occur when someone with rheumatoid arthritis is exposed to this dust that causes pneumoconiosis, and we shall have multiple pulmonary nodules forming. For example, in people who are coal miners or people who have exposure to silica dust and have long-standing rheumatoid arthritis, this is why this condition, Kaplan syndrome, is going to be commonly seen. So when it comes to the pathophysiology, is that when you do the dust inhalation, macrophages are activated, and we have formation of necrobiotic pulmonary nodules. And it's often asymptomatic, but they may have cough, dyspnea, and the nodules may also cause cavitations, and this is going to reduce on the lung capacity of this person. So the diagnosis is made from the history of having rheumatoid arthritis as well as exposure to occupational dust. And when you do the chest imaging, we're going to see this. And sometimes a biopsy can be considered, and the management is going to be treat the rheumatoid arthritis and of course stop the exposure to these dusts. But the cavities may need to be surgically removed, or if they're infected, we may need to remove them, and also manage some complications like development of the pneumothorax. Then when we look at the Felty syndrome, so the Felty syndrome, we're going to have a triad of rheumatoid arthritis, splenomegaly, and the neutropenia. So what happens is that we have this formation of autoimmune antibodies that are going to be deposited in the spleen, and the spleen is going to undergo enlarging it. And when it enlarges, it's going to become hyperactive. Once it's hyperactive, it's going to destroy the neutrophils. So we have a neutropenia, and this is very life-threatening because once you have low neutrophils, it's very easy to contract infections, and these infections could eventually lead into death. So the diagnosis is going to be if we have a clinical triad of rheumatoid arthritis, splenomegaly, and neutropenia, and when we do the labs, we have an ANC of less than 2000, as well as a high rheumatoid factor and anti-CCP antibodies. And the complications mostly is going to be life-threatening infections. Then the management, we're going to give Methotrexate, which is basically the first-line management again for rheumatoid arthritis. So we're going to treat the rheumatoid arthritis. We're going to try the biologics if this is refractory, if we're not seeing any improvement. And we can do splenectomy as a last resort. So in regards to the pharmacological therapy, the mainstay drugs and the most commonly used are the disease-modifying anti-rheumatic drugs. And in all patients, we are going to initiate anti-rheumatic drugs. So the first line is going to be Methotrexate with their folic acid, and we are going to use this over a long period of time, and we are going to titrate this Methotrexate slowly. You can start at 15 milligrams and titrate it over a long time until we have 25 milligrams, or when we have adequate response. And if we have inadequate response, we may consider adding another disease-modifying anti-rheumatic drug, and most times they consider moving to the triple therapy, where we give Methotrexate with sulfasalazine as well as hydrochloroquine. And if we're having a partial response to this triple therapy, we can try to add a low-dose glucocorticoid like 5 to 10 milligrams daily of prednisolone for a short period of time. Then we can also try to initially, sometimes you can give them Methotrexate with the prednisolone 30 milligrams daily. And as we are increasing the dose of the Methotrexate, we shall be tapering down the dose of the prednisolone. Then have the biologic therapy, which is indicated if we have a high disease activity or a DAS28 score of greater than 5.1. And DAS28 is basically a score that you use to determine the response to the medication you're giving. And if it's greater than 5.1, it's an indication of starting biologic therapy. And the first line, we have the tumor necrosis factor inhibitors, we have the JAK inhibitors, and we can consider this mostly for the DMARD refractory patients. Then we can do dose reduction after 12 months in 50% of the patients who have rheumatoid arthritis. Then we have flares, where someone is okay for some time and then they have a flare and they have a lot of pain. And we can treat these, if they are transient, we can consider giving intra-articular steroids or a short oral steroid course, like prednisolone. If they are sustained, we may consider switching the DMARD therapy or we switch to biologic therapy. Then surgery, we can do synovectomy, we can do joint replacement, and can do other procedures like metatarsal head excision for the metatarsal phalangeal subluxation, and then we can do neurosurgery for anteroaxial subluxation. So we've come to the end of this video, but before I end here, I would like to maybe give you some of the tips that can help you identify or tell apart rheumatoid arthritis from osteoarthritis. So what happens in osteoarthritis is that we have this, it's going to mostly affect the weight-bearing joints. And when we look at the nature of stiffness in rheumatoid arthritis and osteoarthritis, rheumatoid arthritis, activity is going to improve this stiffness. While in osteoarthritis, the movement is going to actually worsen this. And when you look at the stiffness in rheumatoid arthritis, it's going to be greater than 30 minutes or greater than an hour. But the one in osteoarthritis, the early morning stiffness is going to be less than that time. It's going to be less than 30 minutes. And when it comes to the management, here we're going to have DMARDs and everything. But osteoarthritis is mostly going to be management of the pain. Maybe we're going to do some lifestyle changes, and that is what is mostly going to be the mainstay. We do not have DMARDs having a thing there. Then the genetic component is mostly going to be rheumatoid arthritis, and it's not going to be in the osteoarthritis. Thank you very much. My name is Benjamin. We have come to the end of this video. I'd encourage you to subscribe for more of these good high yield summaries. Thank you very much.